Alright, so in this PowerPoint we're going to be talking about the skeletal system. So the skeletal system is made up of roughly 206 bones, okay, give or take. I say roughly just because a lot of the times those bones will fuse together just as a result of development and growth. Um, the skeletal system provides support, protection for everything in your body. It is the base of movement. Can't speak. It is where movement is occurs. Okay, based on the muscle attachment and muscle contraction and so forth. Okay. Other functions of the skeletal system. Okay. Besides movement. Okay. Mineral storage. Okay. Obviously the bones themselves, and hemopoiesis, which is the development of red blood cells, which occurs in the bone marrow. Okay. The skeletal system is divided or broken down more into the appendicular than axial. Okay. So the axial is more kind of like your core area. Okay. And then the appendicular is all your limbs, all your extremities. Okay. So just a quick kind of overview right here. Okay. Obviously, besides the skull and the facial portions. Okay. Right here we have the sternum. Okay. The clavicles. Okay. Behind we have the scapulus. Okay. In here. Okay. Your shoulder blades. For the most part in this class, I'm going to use all the scientifical or the medical jargon. Okay, if you will, the proper names of them, not shoulder blades. I'm going to use scapula. Okay. Here we have the humerus. Okay. And then we have the radius and ulna here. Okay. To identify where one is versus the other. Okay. The radius always is on the same side as your thumb. Always. Okay. So like in here, my radius is always right here. Okay. Even if I turn here, my radius is still my thumb. Okay. And ulna is always opposite. Okay. Your radius always rotates around your ulna. Okay. Hence radius. Okay. Down the wrists, we have your carpals. Okay, in here. Your metacarpals, which is here to here. Okay. And then your phalanges. Okay. We have our vertebral column here. Goes all the way up and down. Your ribs. Okay. Here we have your pelvic girdle. Okay. Or your hips. Okay. And down we have your humerus. Okay. And then we have your tibia and fibula. Everyone likes to confuse them or combine them. And what's the best one I got? Your fidea or fibula. Anyway, just make sure you always don't get them confused. Okay, your tibia is always the big one, and your fibula is always that kind of lateral outside edge. Okay, and then we have your tarsals. Okay, and your ankle, your metatarsal, which is more your foot, and then your phalanges, which are your toes. Okay, so different types of bones. There's long, short, flat, irregular, and sesamoid. Okay, so your long bones. Okay, that's ideally what they are. They're long. Okay, long, cylindrical. They don't bend in any way. These are usually your levers where a lot of your motion occurs at. So your phalanges, tibia, fibula, radius, ulna, and humerus, all your major long bones. Okay, they have a diaphysis. Okay, this area here. Okay, this long cylindrical portion of the bone. The outer lining of your diaphysis is called your periosteum, which is the kind of that white that you see on bones. That is your periosteum, the outer layer. Okay, deep inside you're going to have your marrow. Okay, you're in that medullary cavity. Okay, you're going to have all that kind of marrow, which is really, really important for blood production. Okay, on the ends of the bones, okay, your epiphysis, you see right here. Usually our proximal distal epiphysis. Okay, is always at the end of the long bones. Okay, usually kind of enlarged. That just helps with articulation with the next bone. Okay, a lot of times that's going to be a very, very compact bone. Like let's say this is a femur. Okay, so like the neck of the femur is very, very hard, compact bone. Okay, that just makes it stronger, less likely to have any kind of fracture in them. Covered in some kind of hyaline cartilage. Really good for cushioning and shock absorption. Okay. We also have the epiphyseal plate, okay, often called the growth plate. You can see this little line in here. Okay, there's another one here. Okay, so this is the tibia and this is the fibula. Okay, so this is the distal epiphyseal plate. Okay, in the tibia, and this is the distal plate in the fibula. Okay, so this is where all the growth occurs in those long bones. Okay, is in that growth plate. Depending on your age, stage of life, the growth plates will actually close. Okay, which results in no more growth in them. They can close prematurely. We'll talk about it here in a little bit on the epiphyseal plate fractures, which can result in abnormal bone growth during that time. Okay. Short bones. Okay, short bones are obviously they're short, small cube-like bones. Okay, like your carpal bones, short bones. Okay, primarily provide support, stability with little to no movement in them. Okay, you see all your carpal bones here, which I'm not going to quiz you on all the different names. Okay, next we have flat bones. Okay, flat bones provide a good amount of protection. The important ones are your ribs, sternum, clavicle, scapula, and skull. Okay, so your flat bones, let's say your ribs here, your ribs actually bend. Okay, they're not round like we used to see in the cartoons. They're very flat, and they bend, which allows your thoracic cavity to expand and contract during breathing. Okay, which is very, very normal. Okay, obviously when it goes too far or it goes too quickly, it results in some kind of fracture to any kind of those ribs. Your sternum right here in the front. Okay, here is your scapula here, or your shoulder blade. Your skull is also a flat bone. Okay, not your facial muscles. Okay, just your skull. Okay. Next we have irregular bones. Okay, so these aren't really classified in any major area. Okay, just because they're very, very unique. Okay, for example, your spine is all regular bones. All your facial bones. Okay, as I said, not your skull. That's a flat bone. All your facial bones are all irregular. Okay, your hips. Okay, your ischium, your pubic. All those are all irregular. Okay, because they're very, very complex. They don't fit in any other category. The last one is going to be your sesamoid bones. Okay, there's usually some kind of embedded within a tendon. The major one is your patella or your kneecap. Okay, that is a sesamoid bone that is encased within your quadriceps tendon. Okay, if you straighten your leg out and you don't kind of contract it, you just kind of let it like relax. You can actually move your patella back and forth. You wiggle it a little bit. Other areas you'll find sesamoid bones, you'll find them just under the big toe. You see these little pictures right here. Maybe hard for some of you guys to see. You also have another one in your thumb right here. That just allows for better kind of leverage on those tendons for that bone to kind of, for those joints to kind of bend, as you will. All right, a little bit back to bone growth. Okay, going back to the epiphyseal plate. Okay, or this is where all your growth occurs. Usually by 25, all growth stops. Okay, because all those growth plates, our epiphyseal plates, are closed. Okay, if they close too early, it results in some kind of injury. Okay, here is roughly, I mean, it doesn't fit every single individual, but it's roughly the same. Usually your proximal ulna and distal humerus close about 15. Okay, and the latest is your vertebrae and your ribs close about 25. That's why. So about 25 years old, you're usually done growing. Okay, some people it's a little earlier, some people maybe a little bit later, but usually around that. All right, injuries to growth plates. So there's 5 different types of injuries. Okay, they're classified as Salter-Harris epiphyseal plate injuries. Okay, you see here's a normal growth plate, whichever one you want to see. Okay, so here is the epiphyseal plate right here. Okay, we have your diaphysis and your epiphysis here. Okay, so type 1 is some kind of separation. And these are all types of fractures, just so you know. Okay, and the difference between a fractional break is there's no difference. FYI. A fractional break are the same thing. One's not worse than the other. It's just the layman's version is break, and all the medical form is a fracture. Okay, whatever type it is. Okay, and so I use fracture all the time, so you'll hear that. So always different classifications. So this type 1 here is some kind of usually like dislocation of the fractures. That distal epiphysis area is some kind of broken off and shifted. Okay, type 2 Saltaharis is the same thing plus a little bit of a kind of fracture of the distal diaphysis. Okay, type 3, okay, is part of the epiphysis is fractured along with the growth plate. 4 is all the way through that diaphysis and epiphysis. And 5, they also term that a crush injury. Okay, you crush your epiphyseal plate. What happens here, actually I'm going too ahead, is if you crush that growth plate or any kind of the Saltaharis fractures, that growth plate will close prematurely. Okay, because as that bone heals, it's going to close that growth plate, which if you're a little bit older isn't like as big of a deal, but when you're younger and you're still growing, that's a huge deal, because if that growth plate closes too early, that now can stunt your growth. Okay, so it also can affect the different like lengths of some of your extremities. For example, let's say this is a femur, okay, and you pick a type of fracture here, and that closes that growth plate prematurely. Let's say you're 15 years old. Okay, if I go back to this picture here, I don't have femur in here. Okay, let's say your femur closes by 20 years old. Okay. Okay, so by 20 years old, 15 years old, you have a horrible accident. You fall off a roof doing something dumb. Alcohol is probably involved. And you have a type 3 Saltaharis fracture. Okay, so that growth plate is now closed on your left leg. Well, your right leg doesn't close for 5 years later. So you actually grow half an inch on your right leg. But your left leg doesn't grow anymore because that growth plate is now closed. So now you're taller in one leg versus the other, which affect a lot of things on the road, walking, how quickly you go through shoes, and so forth. So that's very, very important. A lot of time when like adolescents and children and young adults, when they do kind of have any kind of fracture, that's usually a major cause of concern for the overseeing physician is where is it, has all their growth plates closed or not. If it hasn't, a lot of time they'll do some kind of surgery to make sure that it doesn't close prematurely. And there's a number of reasons, ways they can do that. I'm not going to get too in-depth on all that because that's going to be specific to the injury physician and the need. Okay. I've seen them do a lot of surgeries to put plates in to kind of make sure that growth plate stays open. I've seen other ones put plates in to kind of close the growth plate because they just keep growing. Okay. I had one guy when I was working in high school, and he was 6'10", and then to go in and put growth plates in both of his tibias to close those growth plates because he just kept growing, and his muscles couldn't keep up with the growth that occurred, and so he was getting muscle strains, and he was super tight because he was getting so long his muscles couldn't stretch out with him. Okay, so that's very, very important. Most times you'll see all our fractures on the growth plates in individuals that are going through their growth spurts at the times. So for females, it's usually about like their freshman year in high school or their 8th grade. You'll see a lot of just like a normal fall. Either you trip and fall, or you're doing a sport and you fall and you put your hand out like normal to try and catch yourself, and it results in some kind of fracture, usually to a growth plate. For males, it's usually freshman, sophomore year of high school to get more of those fractures. I was working as an athletic trainer in one of the Clovis schools for like 10 years, and I would run out of splitting material because of how I would get like usually 3 to 4 fractures a week in amongst all sports. Not one's better or worse than the other, but just because during their growth spurts, their episteal plates are so prone to fractures. They'd be a little bit weaker during all that growth, during the growing, that where you get a good amount of fractures. I did a lot of referrals to a lot of physicians for whatever the injury was, or sorry, whatever type of fracture it was. All right, the circumference growth, okay, or lack thereof. Okay, so bone is laid down when it's needed and taken away when it's not. Okay, so what it is the osteoblast and osteoclast play a factor in the thickness and kind of strength of the bones. Okay, so osteoblast, okay, is this kind of bone cells that are produced on the internal layer of the periosteum, and the osteoclast or bone. Sorry, currently bone is reabsorbed, okay, by the osteoclast. Okay, so one lays down and one takes away bone. Okay, and it takes away to be absorbed through your body because it needs the calcium. Okay, and it lays down to store calcium and to increase bone growth. Okay, and they're constantly doing this. They're never really stopping. Okay, so the demand on those bones obviously varies depending on the, let's say, sport or activity or whatever it is. So the more active you are, the thicker your bones are as a result, because they need that more stability. Okay, so the osteoblasts are going to lay down more bone when it's like needed. Obviously, like you consume more calcium and other minerals to help that bone growth to occur. So it's to lay down more bone growth, and your bones actually get thicker. Okay, a little bit more rough. Okay, so if you look at a college tennis athlete, their serving hand or serving arm, all the bones in it, okay, are substantially thicker than the non-serving hand. Okay, just because the amount of forces that needs for that serve, okay, is going to be obviously greater. So over time, they're going to lay down more bone. Okay, so there is a thing as actually being big boned to an extent. Okay, the osteoclast will obviously reabsorb that bone when it's not needed. If you're a couch potato all COVID, your bones aren't going to be quite as strong. I'm not saying they'll be weak, but they're not going to be as thick as they would be if you're continuously active. Okay, your osteoclast also absorb that bone when they need the calcium. Okay, and they're constantly doing this. Also going back, so when you have any kind of fracture or break, the osteoclasts absorb all that dead bone, all those dead bone edges, and it just absorbs it. And the osteoblasts are really important for kind of the healing process of those bones. When we talk about a stress fracture, if you ever heard that form, a stress fracture is a microfracture in a bone. Some can be painful, some can be not painful at all, okay, depending on like the symptoms or the activity. And what's crazy about stress fractures are they don't show up in x-rays until about a month after they start feeling pain. Because it's so small, normal x-rays can't pick it up. It's too minute. So what they're going to see after about 3-4 weeks on an x-ray is they're going to see a substantial amount of osteoblasts forming this callus on the bone. Okay, so you'll see this kind of raised area around the area to where you'll see like a callus of bone of just osteoblasts trying to lay down a lot of new bone for healing. All right, so a change of bones kind of over time. So a common one is Osgood-Schlatters disease. Very common in adolescents, especially the active ones. So this is a development of inflammation, usually a bony deposit, or an avulsion fracture of that tibial tuberosity. So the tibial tuberosity is just an area of bone Okay, it's usually right here on your tibia. Okay, in the pictures here, it's actually raised. Okay, so this is like the worst scenario here. So this is an avulsion fracture. So an avulsion fracture is just a different classification of fracture, to where it pulls wherever that tendon attaches, it pulls that bony attachment off. It avulses off. Okay, so the tibial tuberosity is really important because that's where all your quad muscles insert on. Okay, there's it right here under tibial tuberosity, and a result of I don't know what the issue here with this X-ray was, but they avulse off that tibial tuberosity. Very, very painful. I've seen some worse ones, but this is a really, really good X-ray to show you that. So usually the normal thing you'll see with osgood Schlatter's, you'll see inflammation, patellotinnitus. You'll see this really distinct bump that forms on the tibial tuberosity right here, and that's usually what it is. Usually that osgood Schlatter's is more of a landing issue than a jumping issue. They usually call it jumper's knee. It's really kind of a lander's knee because that individual, usually adolescents, can't land properly efficiently. They land very stiff, they land very hard and like loud, for example, and they don't absorb that force when they land. As a result, your tendons take all that brute force of it, your tendons and bones, which can result in worst case avulsion fracture, but usually some kind of inflammation development right here. Okay, to where if you land like softer and more control the landing, which is harder than you think, especially teaching in adolescence, all your muscles are going to absorb all that forces, and less likely on your tendons and bones. Okay, so the osgood Schlatter's is at your tibial tuberosity. There's another one called Larsen-Johansson disease, which is the same thing. It just originates at the inferior pole of the patella. Okay, so those two different ones that can happen. Another one we'll talk about is the muscle-bone strength imbalances, which can happen. So the growth factor between the bone length and the muscle tendon unit. Okay, so the rapid growing of your femur, for example, during a growth spurt, and the tibia place large strains on the patella tendon and tibial tuberosity. So a lot of people call this growing pains. So your bones grow very, very quickly during your growth spurts. Okay, as much as a few inches over like a summer, for example. And their muscles can't really keep up. Okay, even though your both your muscles and bones have very, very good blood flow, which can result in increased healing times or optimal healing times and so forth, still your bones will grow faster than your muscles can keep up. So as a result, a lot of that extra strain gets placed on those kind of tendons as a result, because they just can't keep up with everything else. That's kind of that weak link at that time. And that's where you'll see, like, let's say boys, for example, they'll get really, really tall, they'll get really, really tight, they lose all their flexibility, and they get a lot of like tendinitis and osgood Schlatter's and stuff like that occurs. And as a result, over time, like when your growth plate's closed, because there's a epiphyseal plate here as well, you actually grow out of osgood Schlatter's, okay? Because your growth plates are closed, they'll be very, very strong, and that's it. Oftentimes, the damage is done, and it will have this permanent kind of bony deposit here. They'll be very, very distinct, and they're going to have that usually the rest of their lives. Nothing really wrong with it. That's just how it is. Okay. Another thing is osteoporosis. Okay, so this is a bone disease where the bones become very, very porous. Okay. Your body absorbs needs a lot more calcium at this point. So your bones just become a little bit more fragile. That's all it is. And this is very, very important when, let me go back to some of the thicker bones, or the thicker portion of the bones, like let's say the neck of the femur. Okay, to where there's a very, very compact kind of bone area gets more porous, results in a fracture usually right here at like the neck of the femur, for example. Okay, so a lot of time you'll get the fractures in the hip is going to be at the neck of the femur, just because this is a kind of big kind of angle for a lot of the forces to kind of play a factor on. Some other things, overuse injuries. Okay, very very common in younger athletes, just because they put too much forces on their body. Okay, so one is little leaguer's elbow. Okay, so this is a premature closing or some kind of fracture of the epiphyseal disc up here. Okay, so this is your raised ulna. As you see, you have a fracture right here, some kind of usually a avulsion fracture. Okay, because of all the flexors that attach right here. So all your like wrist and hand flexors all attached to this spot right here. Okay, so usually overuse, or let's say for little leaguers, okay, usually it happens this is they do too much throwing. They throw, let's say, curveballs when they're not supposed to at this young of age. They throw more than they should be. They don't have enough rest time or days in between higher throwing days. Results in this kind of avulsion fracture or fracture in itself. So usually results in they have to throw a pin or a screw in there to keep it together, and then they're shut down for a year, give or take. Okay, so there's a lot of rules now around like little leaguer's elbow to where you only can throw certain types of balls. You have to have you can only throw so many balls in a day. And it depends on your age is a big factor. And there's a whole like chart that shows you what it is. It depends on how many balls you throw in a day. Depends on how many days off you have from throwing. So like for like a high school senior, like let's say 18 years old, pitcher, they can throw a max 120 balls that day. And usually a lot of coaches do not let them even get to that point. And they can't go over that no matter what. There's usually, I think the new rule here in the Valley on that is they have to have a pitch counter going on. So usually coaches don't want to get to that point because the closer they get towards it, the more likely they are to kind of rupturing their UCL, which is that kind of major ligament in the elbow, or having some kind of pitching injury like this avulsion fracture here. So let's say he throws 100 balls that day. Well, that will dictate a 3-day rest afterwards where you can't throw at all. Okay. So a lot of rules around that. Another thing we'll see in gymnastics and swimming is a injury to the disc. Okay. So this is a spondylolisthesis. Okay. There's also a spondylitis and I can't remember the other spondy ones, where some kind of back injury to your disc. Usually in gymnastics is a big one, and then swimmers is a big one. With the what is it? It's the extension of the back. So the extreme extension of the back, especially multiple times, results in this kind of fracture, dislocation, so forth. Okay. All right, next on joints and movements. Okay, so joints are broken down to different classifications. Okay, we have the pivot joint here. Okay, so like let's say it's your C1, C2. This is where that rotation occurs. Okay, down here at the hip, we have that is at the true ball and socket joint. Okay, at the elbow, we have a hinge joint. Okay, we have a saddle joint. Okay, in the thumb, okay, it kind of sits in the saddles like that. So pretty much the only joint that has that. We have a plane joint in the ankle, where it kind of sits on one top of another and kind of can travel on different planes. We have a conoid joint, which is another kind of multi-plane joint down in the wrists. Now some other ones, like the shoulder joint, the glenohumeral joint in the shoulder, is technically a ball and socket joint, but is a really shitty ball and socket joint. Okay. So where you can see we have a nice big socket for the ball up here in the femur. It is kind of inversely for the shoulder. Okay, instead of a big socket, it is a small socket for a big head. Okay, so like this is the true like ball and socket joint. Okay, we have the socket. Okay, we have the ball in here. It kind of rotates really nice in there. Okay, this is like a more true ball and socket. For the shoulder, it is, let's say we have a do I have any kind of ball in here that would show that? Okay. let's say this is the socket, okay? And then this is the ball. Okay, so this is the ball and socket of the shoulder. Okay, so this is where that rotation is going to occur. And there's other forces on there that help that shoulder joint be a little bit more stable, but it's not a true ball and socket like the hip is. Okay. They also don't have the knee in here. The knee is also a hinge joint. It's a little bit different from the normal hinge that you would see here of the kind of only bending and extending. Okay, to where in the knee there's more of a hinge and shift. For example, if this was the femur, and this is the tibia, so instead of being that like hinge, like you would see, it kind of rotates down underneath. Okay, for flexion and extension. Okay, but just know that the knee is still considered a hinge joint. There is a little bit of rotation that doesn't happen in the knee, but not a lot. Movement is also based on some different other factors. So you have your synarthrosis joints, which are pretty much immovable or very, very slightly movement that occurs in them. You have your amphiarthrosis, which is limited motion that occurs. A little bit does occur. And then you have your diarthrosis, which is your freely movable joints, which is most of the ones here. Okay. All right. So first we have your synarthrodal, or your immovable joints. Okay. So we have like the sutures of the skull. Okay. So these are still a joint. Okay. It connects one bone to another, but no motion occurs. Okay. And then we have the gymphosis joint. Okay, which is that your teeth sitting in your jaw. Okay. It's called your gymphosis. Okay. So a little motion occurs here, like a little bit. Okay, but usually there's not a lot. Okay, and then your syndesmosis joint, which is one of your joints in your ankle. Okay, and this is pretty much where your tibia and fibula kind of articulate together, and a little bit of motion occurs here, but usually not a lot. Okay, so these are all synarthrodal joints. Okay, next one is we have amphiarthrodal. Okay, which is some kind of limited motion that occurs. Okay, for example, we have the pubic symphysis, okay, which is down here in the middle, and down here at the hips. Okay, and then we have your intervertebral disc, or that symphysis in between them. Okay, so where there's not a lot of motion that occurs. A little bit does, especially a little bit like the rocking back and forth, a little bit of rotation that occurs, but not a lot of motion occurs here. Okay, so those are the major amphiarthrodal joints. Okay. And then we have your diarthrodal ones, which are ones I've talked about previously. Almost all your diarthrodal joints are also called synovial joints, which they have the synovial membrane or synovial capsule that surrounds them. So this capsule, what it does is it's filled with some kind of synovial fluid, helps lubricate that joint, helps keep the inner areas of that joint kind of nourished. So that synovial fluid in there helps provide nourishment as well as lubrication to all those inner areas. And is really, really important for a lot of those different things. Okay. It's a little bit more on the joint capsule. It can vary in size. Okay. It's made of some kind of fibrous tissue, which is very, very strong. Contains a lot of proprioceptors, which is these different kind of nerves, if you will, that kind of help dictate joint angle, positioning, temperature changes, and so forth, and pain as well. So this kind of joint capsule or synovial membrane can get inflamed. Okay, a lot of times if you dislocate your finger or whatever it is, or you severely sprain your finger, the capsule can be affected as well. A lot of times the ligament is encased within that capsule. It results and it gets bigger. And so let's say you sprain your finger a really good time or multiple times, you actually see that knuckle get bigger on usually both sides. And that's just a really bad inflammation of that capsule. You can also really see the joint capsule really good on individuals that are like super skinny. Maybe you have a grandparent that's just really skinny and you can see like their fingers. Instead of being kind of like, I don't want to say normal fingers, but the joints is very, very pronounced. Okay. And that is, you're looking at the joint capsule. Okay. And then all that that capsule contains all that synovial fluid, which helps keep all those inner areas very nourished. For example, if you have a meniscus tear or meniscus injury in your knee, meniscus is this kind of tissue that's like a shock absorber in your knee. Well, the inner areas of your meniscus don't get any blood flow, so they don't get any nourishment. So the only form of nourishment that you can get is through your synovial fluid. Okay, so that's very, very important for some of those different areas. And that is it for the skeletal system.